My name is Dr. Alycia Cleinman. I'm a geriatrician in Chattanooga, Tennessee at the CHI Memorial Center for Healthy Aging. This is my amazing geriatric nurse practitioner, Cassie Rodriguez. We are starting off our wonderful dementia lecture series aimed at caregivers in the community, maybe experiencing or wondering about this disease process. We're beginning with the dementia umbrella. Before we start our series, I did want to give you a little bit of information about what we do here at the CHI Memorial Center for Healthy Aging. I am a board-certified geriatrician, and I practice primary care for patients 55 and older, as well as do geriatric consults for new onset memory loss, dementia-related behavioral problems, gait assessments, or sometimes just geriatric consults in general for somebody who's looking for a more in-depth look at their medication. So we're ready to talk about the dementia umbrella. This is one of my favorite topics. So Cassie is going to lead our conversation, just kind of directing us with some questions. Why don't you start, Cassie?
So let's just get to it. What is dementia?
So that's a really good question, Cassie. So dementia is that somebody has two areas of memory or thinking that are impaired, and that is affecting their daily function. So daily function is actually well defined by activities of daily living and independent activities of daily living. When we say daily function, we're typically talking about independent activities of daily living. Those are things that require a higher level of cognition to perform. So balancing your checkbook, which none of us really know how to do anymore, cooking, managing your medications, driving. So if somebody maybe knew a recipe for a long time, like your grandmother or something, and all of a sudden they start forgetting what's in there, that's the serious impairment. So they would have to have some impairment in those, as well as two areas of memory or thinking that's affected. So when I say memory or thinking affected, that is not just what we typically think of, which is short-term memory loss. It also includes judgment, so ability to make more higher level decisions, like should I sell a house? Should I sell a stock? It also includes things like communication and language. So all of a sudden they're having issues finding words. Fine motor skills. I can't really button my shirt anymore is a common one that we hear. And then the last one is actually visuospatial abilities and depth perception. So if somebody was an artist and they were able to maybe draw a 3D object, and they all of a sudden can't do this. But the main thing to remember too is that we're talking about changes. So, I mean, if you weren't able to draw a 3D object and it's not new, that's not pertinent. But if you were, it is.
What is normal aging?
Yeah, so I get this one a lot because people are always concerned when they're older and they start having memory issues, is this normal or not? And they start talking to their friends, comparing themselves. But that's not what they should really do. They should have a conversation with their provider about whether or not what they're experiencing is normal. In general, normal aging is that you start having issues with learning new things. So if you're like, I'm going to go ahead and play pickleball now, and I never played it before, and you're having trouble learning how to play pickleball, but it does come. It's just slower. So that is normal. And another thing is that you're not able to really multitask anymore. So people will use more aids. They'll use lists, they'll use calendars, but the most important thing with normal aging is it does not affect those activities of daily living. So they're still able to drive, cook, shop, managing their finances and medications. The other thing that I want to talk about is kind of a precursor to dementia. It's called mild cognitive impairment. So that is an important thing to recognize and monitor. It means that they do have some sort of deficit in their thinking or memory that we had talked about before, but at this time, it's not affecting those activities of daily living. That is the main differentiator between dementia and mild cognitive impairment. There is a risk of about 20% that those people could later develop dementia, but that's 80% chance maybe that they don't.
And so what would be the difference between Alzheimer's and dementia?
A lot of patients ask that, don't they? Yeah, it's a pretty common question. So that's where the umbrella comes in. So the umbrella is dementia. Alzheimer's is a subtype of dementia. So you have that memory loss or cognitive impairment, and then it's affecting the activities of daily living. Alzheimer's is a very specific type of dementia. There's a lot of types of dementia. So I'm actually going to start with my favorite type of dementia, which is Lewy body dementia. I find this one to be quite interesting. Do you?
Mm-hmm.
Yeah. So Lewy body dementia is defined by 3 core features. So one is visual hallucinations. And these are very vivid visual hallucinations. These patients talk about having elves that go to their house, hide behind their television, children that they're cooking full meals for. They're seeing rhinos in their yard. Pretty interesting. And they are convinced they are real. They are real to them, which is true. And that's a really important differentiator because of a lot of other things like Charles-Bonnet syndrome. When you have eye issues and you have visual hallucinations, you know they're not real. But these people believe this is real. So the second core feature to this is that they can develop Parkinson's symptoms. So they don't necessarily have Parkinson's disease, but they'll start walking like somebody who has Parkinson's. They'll have trouble picking up their feet. They'll take multiple steps to make a turn. They'll start having a resting tremor, like that classic pill rolling. And then the third core feature is memory loss itself. Now, the tricky thing with Lewy body is that all 3 features have to be presented within 1 to 2 years of each other. So it feels like it's rather rapid when it's happening, but that's a definitive feature of it. Sometimes we see patients who have 1 or 2 core features, but the third one hasn't necessarily quite occurred, but we do expect it to occur. And so those people, we look for what's called minor features of the disease. That is something like REM sleep disorder. So when you're in REM sleep, you're actually supposed to be frozen. These people will get up and act out their dreams. So they'll get up and start punching the air or kicking their wife. Full blown acting out a dream. That is abnormal. It's a REM sleep disorder. Yeah. Another minor feature is something called an antipsychotic sensitivity. So a lot of these patients will have maybe 1 feature present, 1 core feature like Parkinson's or visual hallucinations. And they'll get treatment for one, and it's like a seesaw. It'll throw them into the other one. So if somebody has Parkinson's and they are given Cinemat, Parkinson features, given Cinemat, then all of a sudden those visual hallucinations come about, and they come about fierce because of the medicine. If they have the visual hallucinations come about first, which this is an unfortunate situation we've all seen a lot, they then get hospitalized because their family is concerned, understandably so, and they get placed on an antipsychotic. And then they become completely frozen because the Parkinson's features come about. So that is a minor feature, that antipsychotic sensitivity. So we see that a lot when people are in early stages. So I try to keep a close eye out. And if I think somebody maybe has a possible Lewy body where they haven't had all 3 core features, I warn them about the possible features in the future so that they won't necessarily be given medications that could send them the other end of the seesaw. Mm-hmm. So then other types of dementia. So we also have vascular type of dementia. So that is somebody who has had a stroke or some sort of embolic event in their brain in the past. The pattern for that is a little bit different because they actually follow like a staircase pattern. So the progression is they have a big steep drop, they're stable for months, years, then they have another drop in their memory, and they're stable for months to years. It's important to differentiate that from others because people will be scared when they see that steep drop and they'll think something has changed. But if they understand that's the normal progression of the disease, it helps guide them through it. Another interesting type of dementia is frontotemporal. This used to be called Pick's disease. So a lot of people will ask about Pick's disease, and it's now labeled frontotemporal. It has two different variations to it. One is a language variation where people start having word finding issues. They're not able to complete a sentence. And that actually comes before the memory loss, typically in frontotemporal. The other variant is a behavior variant. And they will typically have inappropriate behavior. And that's from that shrinkage in the frontal lobe from frontotemporal. So they will all of a sudden be sexually inappropriate when they weren't before. I've met patients who would randomly go dumpster diving and take out like old spoons and garbage and put them in the drawers. And this is something they never would have done, but the disease made them do it. Another important feature of the frontotemporal is that it can be an early onset. So most patients present before age 60. So that's a big definer for that. It also has a shorter time course to it. Patients with frontotemporal and Lewy body can have as short a life expectancy as 5 years. So much shorter than other types. One of the longest time courses for dementia is actually Parkinson's. One important thing about Parkinson's is that these patients have Parkinson's. They have this diagnosis for many, many years before they develop the memory loss. So 5 to 10 years or more, and then they'll start developing memory loss. So a much longer time course than anything else. But of course, the one you want to know about is Alzheimer's, right? That's the one that most people want to know about. It is the most popular in terms of being the most prevalent and being out in the community as much, and the most research behind it. So Alzheimer's actually has a very slow, steady progression, kind of like linear. So it will be a very gradual change. The average time course for it is 10 years, which is longer than most of the other dementias. One differentiation for that, though, is early onset Alzheimer's. So that would start before age 65. And when people worry about family history, it's really for early onset. As far as a late onset Alzheimer's, that's just more likely as you get older, as you enter your 80s and 90s. The most important thing to remember about all of them is that they are progressive diseases, and they will at some point see the end course of them if they do not pass away from something else, or maybe research will come up with something to stop the progression. The last type of dementia is an interesting one too. It's mixed dementia. So that means that you have two types of dementia, or possibly even three. So what'll happen is you begin with one type of dementia, maybe Alzheimer's, and all of a sudden that slow, steady progression has a big plummet to it. It's just dramatically changed. And so then that prompts us to maybe image your brain again, and we find you've had a stroke. And now you've developed a vascular dementia too. So you actually have a mixed dementia. So it's important to closely monitor all of these patients because a change will prompt us to reinvestigate and see if something else is going on. I've actually seen patients who had Alzheimer's, and then all of a sudden they started having urinary incontinence. They had trouble walking and their memory got worse. And it turned out that they had normal pressure hydrocephalus on top of it. And so then we had to put a shunt in them and they were doing well. So you never know. Close monitoring is important.
Yes, and so there seems to be quite a few types, and it's important to know because of the prognosis and what to expect. Yeah. So how do we diagnose dementia?
So that's a really good question. The first thing is that we take a really good history. So most of what I just said to you depends on what people have observed. So we ask the patient, but typically we're looking for collateral history. So we really encourage patients' family members to be present, their friends if they don't have family members, because unfortunately that happens sometimes. And we're really looking for that extra observation to help differentiate. Then, of course, their physical exam is important. If we see any gait abnormalities that suggest Parkinson features or any specific weakness in some place that might suggest that they had a stroke, that helps to lead us to a diagnosis. But the most important thing is just a pen and paper test, your basic screening tools. So we perform things like mini mental state exams, a MOCA, which is a Montreal Cognitive Assessment for people that have a higher education level. The VA uses something called a SLUMS. And there is always, if none of this really turns out properly, something called neuropsych testing. So that is about 3 hours worth of yeah, oh my, huh? I don't know, do you have 3 hours? Yeah, if you're retired, I guess you do. Huh? So neuropsych test is about 3 hours worth of testing that's kind of specialized to them, done by a neuropsychologist, a PhD. We use that in very particular circumstances because obviously not everybody's going to sit for 3 hours. It is used when what we're getting from our history or exam is not consistent with what we're getting on the test. So maybe you aced the test, but something's obviously wrong by what you're doing in your life or what you're saying to me. So then I would send you for further testing to try to kind of tease it out. Or maybe I think that your depression is overlapping with it, but I've treated it and it's still looking like that, but I just need that confirmation to help me. Then I send you for neuropsych testing. So use very sparingly, but a good tool for those cloudy situations. The other thing is blood work. So we look for any reversible causes. We look to see if your thyroid is off, your B12, to see if maybe you have low blood counts, extraordinarily low, a low sodium level could do it. Blood work is very important. The last thing is brain imaging. So it is a recommendation that anybody with any serious memory deficits have brain imaging. So there's a variety of different images to use. So a head CT is a pretty basic brain image, doesn't give you very much detail. The only time that we'll use them is if somebody has a pacemaker in place, because they're not able to have a brain MRI. But it's not as good as a brain MRI. That gives us our most information. So that's the most typically utilized brain imaging. Other options are PET scans. So we'll use PET scans when maybe a brain MRI doesn't show what we want or what we think we should see. It's not giving us an answer. And somebody maybe has an early onset memory loss. Anything below 65, if we're not getting a clear answer, a PET scan should be utilized. And that'll give us more a definitive information as to whether this is an early onset Alzheimer's, is it frontotemporal, because that does change things in terms of what we do in the future.
And why is it important that we differentiate those types of the dementia?
Yeah. So it's important because of treatment. So the majority of the medications that you see out there, they work for an Alzheimer's type of dementia. So they're not necessarily going to have a good role in other ones. Now, there are some exceptions. Acetylcholinesterase inhibitors like rivastigmine or Exelon have been shown to slightly improve your cognition in Lewy body, but memantine hasn't. So it does help to guide you with what you choose. Now, if you had a vascular type of dementia and it's from a stroke, well, you'd want to prevent another stroke from happening. So that totally redirects us to blood pressure control, controlling our lipids, putting on some sort of antiplatelet like aspirin or Plavix to help prevent another one. So treatment is a good thing. The other thing is knowing what to expect. So what's your life expectancy for that early onset Alzheimer's, that frontotemporal, Lewy body, much shorter life expectancy than a late onset Alzheimer's. a Parkinson's type of dementia, a vascular type of dementia. So that helps people plan for the future. And Chambliss is going to be talking about planning for the future later on in our series, so that'll be really helpful. So that's another reason why it's really important to be evaluated early, so you can plan ahead. And maybe in the future with research, we'll have more treatment options too. So we'll be able to stop things sooner. The last thing about why it's important to differentiate, and the most important to me, is medication side effects. So I talked about that antipsychotic sensitivity with Lewy body. If you don't know it's Lewy body, then you get Seroquel or quetiapine, and that could have poor endings to it. Yeah. Do you have any other questions, Cassie?
I don't think so. That was very informative. I appreciate it.
Well, thanks for joining me today. Well, and thank you all for joining us. I hope that conversation was really helpful. And stay tuned for the rest of our series to help answer other questions that you have about different topics within dementia.